Howdy, I'm Dr. Tony Buffar. I'm from Henry Ford Hospital in Detroit, Michigan, and we have covered several musculoskeletal ultrasound examinations. Tonight, why don't we look at ultrasonography of the ankle? So for the next half hour, why don't you come along with me and let me take you through musculoskeletal ultrasonography of one of the more important joints of the lower extremity. Let's take a look at the ankle. Let's begin. For the ultrasound of the foot and ankle, it probably is best to remember that we're going to be meeting a lot of peaks and valleys. And so you'll have to be pretty generous with gel, especially when you go around the curving parts of the posterior tibial tendon and the opposite peroneal tendons. Here you could see our fellow Dr. Soonmin Kim examining the medial part of the right ankle of a patient. And again, hand position, and of course, like we warned you, generous amount of gels would be very helpful because of the peaks and valleys of the ankle. Like most ultrasound of any joint, we're going to be addressing tendons, ligaments. After that, we're going to take a peek of what essentially is going to be a ligament, which is the aponeurosis of the plantar fascia. You already have appreciated the fact that ultrasound is excellent for peripheral nerves, and we're going to meet another nerve within the tarsal tunnel. We're going to end this lecture by looking at some masses that can be readily examined with ultrasound as far as complaints of the foot and ankle is going to be concerned. We can approach the ankle by taking a look at it in 4 regions, and of course, you meet the patient, you like to look at the anterior ankle first. The important structures to remember here would be the anterior tibial tendon, the anterior recess with its synovial lining, and the anterior inferior tibiofibular ligament. From there, we can take a look at the very important medial ankle and meet the 3 tendons that are responsible for the arch of the foot. The 3 tendons are the posterior tibial tendon, the flexor digitorum, and the flexor hallucis longus. Also in the medial part of the ankle is a very important ligament, which is the deltoid ligament, with the 3 components: an anterior bundle, a middle bundle, and a posterior bundle. And from the medial ankle, let's now proceed to the lateral ankle, where you'll meet the pair of the peroneus longus and the peroneus brevis. Again, both start behind the fibula and go underneath it, underneath the peroneal retinacula, and then the brevis will insert at the base of the 5th metatarsal, while the longus goes through the peroneal groove of the cuboid and inserts on the base of the metatarsals. Also on the lateral ankles, an all-important and the most commonly torn ligament in the United States, which is going to be the anterior talofibular ligament. Again, it's a ligament, so it connects bone to bone from fibula to the neck of the talus. The posterior region of the ankle probably is where most of you will begin to get initiated into musculoskeletal ultrasonography because it has the tendon. The Achilles tendon has its insertion on the posterior calcaneus, and in front of it would be a retrocalcaneal bursa, which allows the very smooth flexion and extension of the tendon against the bony calcaneus. As you go around the horn of the posterior calcaneus, you'll now come to the plantar fascia, which has its origin over the plantar tubercle of the calcaneus and inserts like a fan onto the subcondylar portions of the metatarsals. So since we're already on the posterior part of the ankle, why don't we take a look at the all-important Achilles tendon. The Achilles tendon is an aponeurosis that is formed into a cord-like structure by the medial and lateral heads of the gastrocnemius, along with the subjacent soleus, and fans out like an aponeurosis, becomes a cord-like structure, inserting into the dorsal tubercle of the calcaneus. On grayscale imaging, you'll notice that in a panoramic view, first, let's go backwards because we do have to identify the bone acoustic landmark of the calcaneus. From there, you'll see the distal insertion of the fibrillar pattern of the Achilles tendon. And then it meets the multipennate muscular structure of the subjacent soleus, And all the way down, very little here, you see the multi-pennate structure of the gastrocnemius. In front of the Achilles tendon is the hyperechoic fat pad of Kager's, or Kager's fat pad, also known as the pre-Achilles fat pad. And then in front of that, you'll have the multi-pennate structure of the flexor hallucis longus. Very important now is also the bone acoustic landmarks of the posterior malleolus. Here you can appreciate not only the posterior dome of the talus, but also the posterior talar process. In the long axis view, you'll get to see that the fibrillar pattern of the distal Achilles tendon is exquisitely seen as a fibrillar pattern on grayscale imaging. Note too that in front of it is the triangle of Kager's fat pad and the two bone acoustic landmarks, which is not only the calcaneus but also the posterior malleolus. Here again you see the multi-pennate structure of the flexor hallucis longus. Ultrasound is a tomographic modality, and after seeing it on long axis view, you must also see it on short axis view. Here you get to appreciate the reniform contour of the short axis view of the Achilles tendon, usually at the level of the posterior malleolus, and its hyperechoic bristle pattern in comparison to the fibrillar pattern on long axis views. When diseased, most of the lesions do occur at the area of or at the level of the posterior malleolus. It is said that this is the watershed area of the Achilles tendon, but it also said that this is an area of high torque, and so therefore most of the stresses and trauma should occur at this level. So here you could see on a universal drawing there is the fusiform enlargement of the Achilles tendon at the level of the posterior malleolus, and on ultrasound you get to see again loss of the usual echosignature fibrillar pattern of the tendon. In its place you see this hypoechogenicity, confirming indeed the fusiform hypoechoic swelling of the Achilles tendon at the level of the posterior malleolus, just beyond the multi-pennate structure of the muscular soleus. We told you that aside from long axis views, as you could see on this panoramic view, you must also try to not only apply the Doppler angiography for confirmation of the neovascularity or inflammation that occurs in these individuals, but also in the short axis view for confirmation indeed of the localization of the disease. And here you see that the kidney form, reniform contour has been lost. Instead you have this oval hypoechoic swelling of the Achilles tendon at the level of the posterior malleolus. Jack Donju is a technologist in Toronto, and we share cases as we also give usually lectures in the North American musculoskeletal ultrasound courses, usually in Toronto. Aside from long axis, short axis views, we also could do some dynamic imaging and of course employ power color Doppler angiography. Here, for example, we see the fusiform hypoechoic swelling of the Achilles tendon, and above that you could see a distended vein. The interfibrillar distances are increased as appreciated by the hypoechogenicity between the hyperechoic fibers. And as you go up, now you get to meet the multi-pennate structure of the soleus. Going back down again in long axis view, confirmation of the hypoechoic fusiform swelling where all the edema occurs in this individual, and of course the tapering back to the normal fibrillar pattern as it inserts on the calcaneus. Swinging to the short axis view, we started with a reniform contour, and then the affected side shows the hypoechoic swelling of the entire Achilles tendon. And as we go further up, the aponeurosis of the Achilles tendon meets the styronite pattern of the soleus. Power Doppler angiography shows indeed the positivity of neovascularity that's occurring in these individuals. Note that not only do you have all the neovascularity occurring within the tendon, but also along its border, and of course the feeder vessels coming in from Kager's fat. So again, you could appreciate the floral pattern, the extraneous supply of the neovascularity in these individuals. For confirmation, it is not uncommon that we do spectral display in order to confirm indeed that we're not looking at artifacts but true vessels arising in the affected Achilles tendon. Most tendons have a loose tendon sheath like the long head of the biceps tendon and the posterior tibial tendon. Achilles tendon has a very adherent tendon sheath known as the peritoneum. And here in the long axis view, you see the examples of what's happening to an individual with a mild form of intersubstance edema, but a fusiform hypoechoic distension, or if not, thickening of the peritoneum on the long view of the long shaft of the Achilles tendon. And once you have the increased edema within these individuals, the incidence of the sound waves increases and accentuates the hyperechogenicity of Kager's fat subjacent to the Achilles tendon. And for immediate quick comparison, you could see that the peritoneum is imperceptible in the unaffected side. And from there, you must also, again from the long axis view, confirm the short axis view. The peritoneum is a sheath that invests usually around the tendon, but it's not uncommon that it's eccentrically affected, usually on the more superficial portion of it. Note again too that the reniform contour of the Achilles tendon is almost lost in this Achilles tendinosis, but along with accompanying peritendinosis. For Achilles tendon rupture, you'll notice a soft tissue swelling on the lateral radiograph at the level of the posterior malleolus. And not only that, but you also appreciate the obscuration of the usually hyperlucent Kager's fat on the radiographs. On ultrasound, you'll readily appreciate the loss of the fibrillar pattern of the Achilles tendon, and then you can identify the distal stump from the proximal stump and an intervening hypoechoic hematoma in between these two stumps. In addition, you'll also appreciate the hyperechoic Kager's fat insinuating into the gap between the distal and proximal stumps. On short axis view, you would have had the loss of the reniform contour of the Achilles tendon with its usual bristle pattern. Instead, you have this huge, massive distension also of the peritoneum itself, and in addition to that, you'll see the intersubstance hypoechoic clefts of the tear. Not to forget too, as we've seen on the long axis view, is insinuation of Kager's fat into the gap between these two tendon stumps. In a panoramic view, we have to appreciate the fact that there is a slackening of the usual taut Achilles tendon. We have an interruption of the fibrillar pattern at the level of the posterior malleolus, and in addition, you begin to appreciate the distal from the proximal stump of the tendon rupture. We have hammered away the fact that once you have a vacuum and between the two stumps, then Kager's fat begins to insinuate into that area. It's one of the parameters that we do indeed report. That is because if Kager's fat is not evacuated, then there's no way for the two stumps to coaptate and heal spontaneously. So one of the tests that we do is going to ask the patient to do dorsiflexion and plantar flexion. In dorsiflexion, we may be able to distract the two stumps further apart, and we get to see if Kager's fat spontaneously herniates out or normalizes when you do plantar flexion and dorsiflexion. Note again that it is indeed at the level of the posterior malleolus. In addition, this maneuver helps us determine how far apart the two stumps of the tendons are. One of the things that ultrasound has been very helpful is to look at the adjacent structures of tendons, and case in point would be the bursae that do accompany them. In the posterior ankle, we'll appreciate that the Achilles tendon on MRI has a high intensity abnormality in front of it, representing a retrocalcaneal bursitis. On MR and the sagittal T2 image, you'll appreciate that it is hyperintense but homogeneous. When given some contrast gadolinium in a T1 sequence with fat saturation, the same distended retrocalcaneal bursitis shows a central core of signal void representing the unaffected side. Clearly, therefore, what we were seeing on T2 was mostly the increased signal changes of edema affecting the synovitis, and with gadolinium we now subtract the fluid from the synovia that is affected. Also, we begin to appreciate that there is subcutaneous edema in these individuals. Note that the signal void structure representing the Achilles tendon inserting on the calcaneus is quite intact. But wouldn't it be simpler if we could look at it with ultrasound? On ultrasound, not only do we appreciate the fact that there is an abnormal distension of the retrocalcaneal sac, but the intermediate echoes forming a rind around the retrocalcaneal bursa represents the thickened synovitis. For confirmation, application of color Doppler indeed shows you the positivity, and the positive angiography tells us that this is neovasculature. Now, we can also appreciate that there is hypoechogenicity of the tendon. But the difference now between the MRI and the ultrasound is, look how exquisite we've shown that there is early cortical changes involving this individual with spondyloarthropathy. Those are the long axis views. In the short axis views, or axial views first on MR, first you'll notice that on T1 morphologically that the Achilles tendon appears to be intact. And the decreased signal in front of it represents the retrocalcaneal bursa, both synovia and fluid. For the more fluid-sensitive T2 on axial imaging, now you begin to confirm not only the increased intensity affecting the retrocalcaneal bursa for all the inflammatory changes, but also surrounding the peritoneum of the Achilles tendon. The application of gadolinium on T1 fat SAT confirms that indeed there was a rind of synovitis affecting this retrocalcaneal bursa, but the rest of the signal void represents unaffected, or at least unimpeded fluid. Here you begin to see on a short axis view of the ultrasound first the continued maintenance of a reniform shape of the Achilles tendon, albeit with mild hypoechogenicity representing accompanying but minimal tendinitis. In front of it now you get to see clearly that not only is the retrocalcaneal bursa distended, but there is accompanying rind of synovitis and unaffected fluid, or at least spared areas wherein loculated fluid is present. And with color Doppler angiography, you begin to confirm indeed the surrounding rind of synovitis with neovascularity and a pool of fluid. And this helps us because now we can see the severity of the synovitis, but also if we need to sample either the soft tissue of synovitis or the loculated amount of fluid. Let's go around the Achilles tendon and look at the plantar fascia. Here you could see in a form of fan, it originates from the plantar aspect of the calcaneus going into the subcapital areas of the metatarsals. This aponeurosis tapers proximally onto the calcaneus, and this is where most of the abnormalities would occur. So, on long axis view, you get to see a pacfibrillar pattern of the aponeurosis inserting on the normal cortical surface of the plantar calcaneus. Well, also on short axis view, you begin to appreciate the pacfibrillar pattern of the plantar fascia as it approaches the cortex of the plantar tubercle of the calcaneus. When affected, just like tendons and other ligaments, you'll see this fusiform hypoechoic enlargement of the plantar fascia at the proximal origin of this aponeurosis. In addition, you'll even see some further coalition of hypoechogenicity, which may represent some partial tears. If you correctly remembered that the cortical contour of the normal and unaffected plantar calcaneus was relatively preserved. In this one you could see that there's an overhanging spur with posterior acoustic shadowing. And if you look at the short axis view, what is expected to be hyperechoic packed bristle pattern, you'll see it as very hypoechoic and enlarged with early cortical irregularities affecting the subjacent cortex of the plantar calcaneus. In a split screen view, note the overhanging hyperechoic spur and the posterior acoustic shadowing on the downsloping part of the plantar calcaneus. Leaving the posterior ankle, let's look at the medial ankle, where there are the trio of the posterior tibial tendon, the flexor digitorum longus, and the flexor hallucis longus. The mnemonic that we've kept in mind, thanks to John Louis from Toronto, is going to be Tom, Dick, and Harry. Dr. John Louis from Toronto said that, well, aside from the tendons, you do have the tarsal tunnel. And within the tarsal tunnel, you have the posterior tibial artery, the vein, and the nerve. So therefore, the mnemonic has changed from Tom, Dick, and Harry to Tom, Dick, and a very nervous Harry. Dr. Dewey Lee from Texas points out that there are 2 veins and 1 artery. So therefore, his mnemonic is a little bit longer, which is Tom, Dick, and a very, very nervous Harry. So T for tibialis, D for digitorum, A for artery, V for vein, N for nerve, and finally H for Harry, or flexor hallucis longus. The tarsal tunnel accompanies these 3 tendons, and the flexor retinaculum, which is a very thin fascia, forms the roof. The floor now is made of solid material, which is going to be the medial aspect of the talus, the bony sustenteculum tali, and of course the medial wall of the calcaneus. We already know the contents, as you can read here on the slide. And of course, this is a fiber osseous canal, much like the carpal tunnel. If you dissect the tarsal tunnel and remove the tarsal retinaculum, you can immediately expose the posterior tibialis tendon, the flexor digitoris, and the artery and the nerve, as you can see here, with a slight fascicular pattern. Here you can see the cut edge of the flexor retinaculum over the medial malleolus. Not seen here because it's deeper is going to be the flexor hallucis longus. In the tarsal tunnel ultrasound, the normal posterior nerve is usually hyperechoic and, of course, with a fascicular pattern in the long axis view, as you can see at the bottom, grayscale imaging. And on short axis view is going to have a follicular pattern or a relatively hypoechoic structure in comparison to the hyperechoic anisotropic tendons. Measurements, of course, vary, and you could check that in the literature, but left-right comparison would be best. Ultrasound has great accuracy in looking for masses that would cause compression and change in contour of the posterior tibial nerve, and you could see the accompanying arteries by looking at the vascular effects. Last but not least, another space-occupying lesion, and we'll show some examples of this, would be some neuromas within the tarsal tunnel. An example of tarsal tunnel syndrome is exemplified by this individual here, as we are more or less at the level of the medial malleolus. You'll notice from the bone acoustic landmark of the medial malleolus, you have partially anisotropic, the fibrillar pattern of the flexor hallucis longus, and then you have the fascicular pattern of a nerve, and finally you have the tubular hypoechoic structure of a vessel, presumably the posterior tibial artery. Now, from the tibial level, we're going to move over to the talar level, and now you'll appreciate the change not only in caliber but also echogenicity of the posterior tibial nerve. Again, the relative preserved fibrillar pattern of the flexor hallucis longus at the posterior joint space, or at least medial joint space, of the talotibial area, and a great difference between the mid-segment and the distal segment of the posterior tibial nerve. Here you see the hypoechoic swelling of this nerve, compatible with inherent tibial nerve neuropathy. And with that, of course, it causes some compression of the artery. Once we see that, then you can measure the change in the waistline defect, and you could appreciate the fact that there's at least a 1/3 increase of the size of this nerve and loss of the usual fascicular pattern. But again, left-right comparison is very helpful. Here in the short axis view, first on the affected left ankle, you would appreciate that not only is the follicular pattern of the nerve enlarged itself, but also that its nerve sheath is apparently edematous. And almost imperceptibly, the unaffected right side with the follicular pattern shows you clearly that there was at least a 3 times increase in size for the affected side, and that the follicular pattern is maintained with the posterior tibial nerve on the affected, and that the follicular pattern is maintained on the unaffected side. Once in a while, you'll get a big mass, in this case, a schwannoma. Here you see the enlarged portion of the schwannoma with the ingressing fascicular nerve being preserved, the mass proper within the tarsal tunnel, and then the egressing portion. Underneath it, you could see the sustentaculum tali, and behind it, you begin to see the flexor hallucis longus with a bit of anisotropy. On short axis view, again, the same mass occupying the tarsal tunnel, compressing the flexor hallucis against the medial wall of the calcaneus. In a split skin rendition of this tumor, namely a schwannoma within the tarsal tunnel, we can identify the bone acoustic landmarks of the medial malleolus, the talus, and then the calcaneus. Here you could see the fibrillar pattern of the flexor hallucis longus as it goes towards the posterior part of the ankle. And above that, you'll get to see the fascicular pattern of the nerve tract going into the affected side of the schwannoma, this markedly heterogeneous mass within the tarsal tunnel, and kind of recovers again as a fascicular tract as it egresses out of the tarsal tunnel. Above it, you'll see the tubular structure compressed out in the tarsal tunnel and again recovers as it leaves the tarsal tunnel, which represents the posterior tibial vessels. Once in a while, you get a completely hypoechoic mass within the tarsal tunnel. Again, the insonating waves accentuate the fibrillar pattern of the flexor hallucis longus as it's no longer impeded by the ganglion cyst. Above it, displayed, as you can see, is the entrapped portion of the fascicular pattern of the posterior tibial nerve. The accompanying MRI of this individual will show you a loculated hyperintense mass lesion, and very difficult to appreciate, but possibly maybe a fascicular pattern of the nerve just adjacent to it. And of course, the ganglion cyst, as we already noted, was going to be atop the signal void of the flexor hallucis longus. The same ganglion cyst that we saw in the tarsal tunnel in the long axis view is again also exemplified in the short axis view. But let's begin with the MRI. Here you could see on coronal T2 that there's indeed increased hyperintensity, and the signal aberration represents the ganglion cyst, probably not appearing as loculated as we did on the long axis view. But alongside it, you may get a hint that indeed this punctate hyperintense structure may represent the nerve. On ultrasound, it's probably easier to identify first not only the dumbbell-shaped ganglion cyst and the slightly anisotropic tendons of the posterior tibial tendon, flexor digitorum, flexor hallucis longus, against the backdrop of the sustentaculum tali, but also that the follicular pattern of the nerve has been markedly displaced and compressed against the tarsal retinaculum. It is not until you employ dynamic imaging that you begin to appreciate why these individuals have an impingement type of syndrome. Here in grayscale, you can appreciate the translating fibrillar pattern of the flexor hallucis longus against the tibio-talar joint. And above that, you have this ganglion cyst that also partially splays and translates with the flexor hallucis longus. But when it does that, you could see the buckling of the fascicular pattern of the posterior tibial nerve compressing the posterior tibial vessels. And for confirmation that indeed those are vessels, here you could appreciate the color Doppler angiography with some aliasing because of the dynamic motion that we've employed in order to look at this individual. So you've already appreciated on long axis. Again, you see the fascicular pattern of the nerve being compressed against the translating flexor hallucis longus and, of course, the flexor retinaculum and the vessels too. On short axis view, as the flexor hallucis longus translates underneath the sustentaculum tali, you'll notice the increasing cyst, and of course here you appreciate the vessels, and one more time the follicular pattern of the nerve as it is entrapped between the cyst and the tarsal retinaculum. The tendons on the medial aspect of the ankle is usually affected, and of course the most exposed one is going to be the posterior tibial tendon. A left-right comparison showing that the right posterior tibial tendon is at least twice the size of the unaffected side, and also that there is fluid surrounding partially forming a halo around the affected right posterior tibial tendon. On the long axis view, you'll note that the fibrillar pattern of the posterior tibial tendon is exaggerated because of the fluid around it, representing distension of the tendon sheath of the posterior tibial tendon. And the unaffected side shows you a nice parallelity of the fibrillar pattern of the posterior tibial tendon and an imperceptible tendon sheath. Power Doppler angiography always confirms, indeed, that this is the affected side. So in the short axis view, the tendon has become hypoechoic and you see vessels traversing around it and through it, along with a halo surrounding tendon sheath full with fluid. On radiographs, you readily appreciate the marked distension of the soft tissue and usually dictated as eccentric soft tissue swelling. Posterior tibial tendinosis, again, if uncared for, of course, graduates into posterior tibial tendon tears. The more common ones are the ones that start intrasubstance and dehisce the fibers well within it. And when that happens, therefore, the usually very tight and taut type of posterior tibial tendon now relaxes, and now you'll see a hypoechoic defect, slackening of that segment at the level of the talus, and almost get to appreciate what should be the distal stump from the proximal stump. The intraoperative portion shows again the proximal stump and the distal stump of the tendon, and of course the dehiscing segment that occurred well within this posterior tibial tendon. When that happens now, posterior tibial discontinuity increases over time. Here in these drawings, you could see fluid-filled space between the proximal and distal stumps. Over time, a fibrous scar forms between these two stumps. And of course, the tendon sheath and some more cables and possibly even some threads are left, and that's what you get to appreciate. On grayscale imaging using ultrasound, first let's look at the unaffected side, wherein you see within the malleolar groove of the medial malleolus that there is the preserved fibrillar pattern of the unaffected side, while on the opposite side you cannot find a tendon. And once you employ the short axis view, you'll see that you have an empty malleolar groove on the medial malleolus in comparison to the unaffected side that shows a clear-cut bristle pattern of the tendon at the level of the medial malleolus. There is a spectrum of posterior tibial tendon tears. You already have seen something that dehisces, like wet Kleenex or tissue paper, to ones that transect across the tendons. And usually when transected, they may occur just at the level of the medial malleolus or approaching the talonavicular region. It is the longitudinal tear that's intrasubstance that is a bit more challenging, and we'll get to see that later. We get to see it as a signal void on this MRI behind the medial malleolus. Here you could see a distortion of the contour of the posterior tibial tendon at the level of the malleolus, and the rest of the posterior tibial tendon as signal void clearly being normal into the navicular region. The intermediate signal aberration is very difficult to figure out. It's partial volume averaging, tenosynovitis. But it wouldn't be simpler to employ ultrasound and confirm indeed that the usual hyperechoic bristle pattern of a short axis view of the posterior tibial tendon within the malleolar groove is affected. Seen here is a hypoechoic cleft, giving this usually homogeneous hyperechoic structure a coffee bean contour and surrounding fluid in distension of its tendon sheath, confirmatory of accompanying tenosynovitis with this tendon tear. On short axis view, you not only saw what's happening to the tendinous tendon sheath, but you'll also appreciate the fact that there are changes affecting the flexor retinaculum and some early cortical changes of the bony medial malleolus. In the long axis view, again, what you expected to be uniform fibrillar pattern has an intersubstance hypoechoic defect separating the superficial from the deep side. Again, long axis, short axis view, confirmation of an intersubstance longitudinal split of the tibialis posterior tendon. These individuals intraoperatively will show indeed that it is an intersubstance tear, clearly seen here, as they put a probe into the intrasubstance portion of this individual, mostly in obese or postpartum individuals that have these problems. We've seen the posterior ankle, and now let's look at the lateral ankle, and we get to meet the pair of peroneus longus and peroneus brevis tendons. We will reserve the talofibular ligament when we address the ligaments towards the end of this lecture. Schematically, normally, you'll remember that the peroneus brevis is closer to bone, brevis, B, brevis for bone, B for B. The longus is L, lateral, or for longus, away from bone. They usually sit behind the malleolar groove of the lateral malleolus, right behind the fibula. Those that are affected may usually slide laterally and anteriorly, and once that happens, the fibula begins to chafe against the peroneus brevis. Unfortunately for the peroneus brevis, the longus contributes because it entraps the brevis against the bony fibula. Over time, the bony fibula creates a spur, which now becomes more like a blade. And as this blade cuts and chafes through the peroneus brevis, it will eventually affect the peroneus longus. Illustrated here, you could see that the peroneus brevis has been chafed by the bony fibula and entrapped between the fibula and the relatively preserved peroneus longus. On short axis view, what we will see is that the sometimes normal variant C-shaped brevis has now a cleft. So on this short axis view within the malleolar groove of the fibula, you'll notice that there are 3 tendons when we only expected 2. First, the relatively preserved peroneus longus, but surrounded with some tenosynovitis and the split of the peroneus brevis. But like we showed you in an earlier illustration, that over time, if uncared for, even the peroneus longus will be affected. Thus, here you could see that the hypertrophy of the spur of the fibula now punctures not only the brevis but also the longus. When that happens, now we begin to go see a complete disorganization. We just have too many tendons when we expected 2. So here you could see that the C-shaped peroneus brevis has a split, but the usually oval or round hyperechoic bristle pattern of the peroneus longus equally shows that it is losing and fragmenting its sides. On the long axis view, we expected to see at least only 2 tendons. Instead, we have multiple tendons representing the different fragments and longitudinal split defects of the peroneus tendons. The stress views we employ in these individuals is dorsiflexion and eversion, as you could see here. Sometimes we are going to ask the patient to do it actively, but if they cannot or they cannot follow our instructions, we bolster the calcaneus, park the transducer underneath the fibula, and behind it we look for the 2 peroneal pairs. Here you could see a dorsiflexion and eversion maneuver as shown clearly. If the patient can do it passively, it'll be great, because what happens in the subluxing tendons, as you could see here, they click anteriorly, and both pairs do that. Sometimes the longus goes over the brevis, or the brevis may leave the longus behind. But clearly you can appreciate that from the posterior location, they go anteriorly. The accompanying video clip of another patient, it's not the same patient, shows you that spontaneously this individual can sublux her tendons all by herself on active movement. So this is what we get to see and feel. Now, of course, when you get to see it in this individual, it's very, very dynamic and very, very exquisite. But on ultrasound, we can at least detect the different parts of the tendons, or which pair of the tendon subluxes. And also you may begin to appreciate what's happening to the tendon as the fibula chafes or cuts into either the brevis and or the longus. For the anterior ankle, we're going to take a quick look at the different structures, and of course, very importantly, let's begin by taking a look at the ligaments. The all-important ligament is going to be the anterior talofibular ligament, and again, because it is a ligament, we're going to connect bone to bone. Bony fibula to the bony neck of the talus, and here you see the pacfibular pattern of the anterior talofibular ligament, preserved and intact. When it is acutely sprained, as you could see on the Netter drawing, Now we begin to appreciate a hypoechoic cleft transecting the loss of the fibular pattern or pacfibular pattern of the anterior talofibular ligament, and of course collecting a subcutaneous edema in the underneath the skin of this patient. So this ankle sprains do have to be addressed within 72 hours, otherwise they may heal and bridge, but not normally. You could still see some fluid collection and sometimes some disparity in the echo signature, the usual fibular pattern of these ligaments. Here again, left-right comparison is very helpful. As you could see on the unaffected left side, you could see the pacfibular pattern of the ligament as it bridges from the fibula to the neck of the talus. And an acutely swollen one, again, loss of the fibular pattern, but also note that you might have an avulsion fragment. As you could appreciate here, you got this high-level echoes along the subjacent portion or the submalleolar portion of the fibula, which may represent some avulsion fragments. Once in a while, you may begin to appreciate the fact that the ankle ligaments form a circle. So if you do affect the lateral side, you may also affect the medial side. Here on an AP view, you could see concentric soft tissue swelling of the ankle, lateral greater than medial. But when you get the oblique view, all of a sudden you see this widened medial clear space representing some disruption of the medial or the deltoid ligament. So this will behoove you to quickly examine both the lateral and medial aspects of the ankle if you are concerned about bimalleolar soft tissue swelling. Individuals with deltoid ligament tears will show a widened medial clear space, as you can appreciate on the frontal radiographs, not necessarily a Mortise or oblique view. Left-right comparison is always helpful. Here in a cadaver study where we created tears of the deltoid ligament, you could see that the anterior bundle formed by the more superficial talonavicular and the deeper talotibial, you could appreciate the fact that the pacfibular patterns are again intact. Here on the grayscale imaging on ultrasound, on the unaffected side, you'll see the superficial tibionavicular bundle or superficial level, and then you have the tibiotalar fibular pattern representing the deep pattern. So this is intact, and when artificially created, you could see the disruption, the hypoechogenicity, and of course the retracted stumps of both superficial and deep fibers of this anterior bundle of the deltoid ligament. It's become very important to us to look at the medial portion of the ankle because we have appreciated high ankle sprains. When the deltoid ligaments are affected, we now also concentrate not only on the more inferior talofibular, but also the higher level fibulotibial ligament, also known as the syndesmosis. Here, case in point, for example, we can clearly see that after addressing the lateral portion and the medial portion of the ankle, when we look at the fibulotibial ligament, the unaffected side shows a pacfibular pattern with a little bit of anisotropy on the tibial side. The affected side of the syndesmosis shows you a markedly swollen and distorted fibular tibial ligament with high-level echoes representing avulsion fragments. This has become important to us because from the classical talofibular ankle sprains, we have now come up with the high ankle sprains. So in the professional National Football League players, we noticed that usually the planted foot has an acute eversion and causes a tear of the syndesmosis. And this gives them a lack of a takeoff sooner or later. There's a big difference between treating the classical ankle sprain, wherein most of these individuals might even have just some bandaging or some short week type of casting. In high ankle sprains, we're looking at longer castings and sometimes a syndesmotic screw for these individuals, long enough as 8 weeks, which is already half their football season. So in summary, therefore, we have gone through the fact that ultrasound is the most exquisite modality to look at tendons. We've shown you great cases about the Achilles tendon, the posterior tibial, and of course the pair of peroneal tendons. Also, we've seen that instability of the ankle is usually secondary to ligaments, and that we've seen and appreciated the fact that ultrasound can address the ligaments. In the heel cord structure of the Achilles tendon and the plantar fascia, we've seen nice cases of inflammation of the aponeurosis of the plantar fascia. Last but not least, you have begun to appreciate the fact that ultrasound is being used more for peripheral nerves, and what we started as carpal tunnel, we're now looking at other types of nerves, including the tarsal tunnel. And so with that, I'd like to thank you so much